My name is Caitlin Hicks. I'm an associate professor of surgery at Johns Hopkins University.
Yeah, I'm Dr. Krishna Jain. I'm a clinical professor of surgery at Western Michigan University. And for full disclosure, I also am the president of National Surgical Ventures and founder of Limb Preservation Centers of America.
So I've done a lot of work on looking at trends and sort of different device use in the peripheral artery disease space. I will say for context, most of what I'm going to talk about are trends specifically related to patients with claudication, because I think sort of the usability of different devices, there's a lot more flexibility in patients with chronic limb-threatening ischemia because those people are at risk of losing their limbs. And so doing more aggressive interventions is more acceptable. In comparison, patients with claudication have sort of more conservative routes that you can manage them. So I think the use of really aggressive technologies is slightly more controversial. And certainly in the data that I've looked at, and it has sort of been coming out recently in the last 2 years or so, has shown an obvious and very sort of shocking increase in the use of atherectomy in the vascular and cardiology and interventional radiology spaces. And the predominant place that this is occurring is in the outpatient-based setting, so in ambulatory surgical settings and office-based laboratories.
Yeah, so basically there are 4 kinds of atherectomy devices. And the companies have used technology and call them by different names, but the 4 types of devices are basically an orbital atherectomy device, a laser atherectomy device, a directional or rotational. So companies have created their own versions of these using technology, how to use these devices. So one of the questions we had earlier on was that what are the type of atherectomy devices? So the data is not there if one device is superior to the other, because the data that comes out is all jumbled up in terms of there are specific indication for laser atherectomy, which was proven on in-stent stenosis. It works very well. But overall, most of the data that comes out in the literature is all jumbled up in terms of multiple devices being used in different settings. So, but those are the 4 primary type of atherectomy devices.
Yeah, and you make it an interesting point. I think the challenge with sort of understanding the efficacy of specific atherectomy devices is that atherectomy is a billing code that's just a catch-all code, right? So if an atherectomy device, doesn't matter if it's orbital, rotational, directional, laser, it is billed as an atherectomy and it gets one code. So any types of claims-based analysis, which a lot of this work has been done in for looking at trends, can't distinguish between those. I have looked at the Vascular Quality Initiative data, which does have a variable that allows you to distinguish between types of atherectomy. And unfortunately, it's really poorly populated. Only about 30% of cases that use atherectomy designate the type of atherectomy that's used. So there's not great data on sort of the usability and practices associated with specific atherectomy techniques.
Yeah, you're absolutely right.
I mean, although a lot of the things that I write on probably suggest that I'm not moderate about this, I am. I use atherectomy myself in my practice, but I use it pretty specifically. I use it really in lesions that I think there is not other great technology available. So like behind knee popliteal lesions where you definitely don't want to put a stent. Sometimes I think atherectomy can be useful there, or in really calcified lesions. The only real guidelines that exist sort of on atherectomy are from the Society for Cardiovascular Angiography and Interventions, or SCAI, and they suggest that atherectomy is useful in the femoral popliteal segment for moderate and severe calcified lesions only. That's their indication. I think for sure we each have our own dogma about when atherectomy works and when it doesn't. My real sort of strong opinion is about the fact that atherectomy I do not think works or is necessary or even helpful in all lesions. So I think there's a lot of the controversy is around how much atherectomy people are using and sort of the prevalence of the use of that technology in their practice.
So I would agree with everything you said, actually. So from my writings, you may look that I challenge that sometimes, which I do. And the reason I do that is because the data is not there. The problem is that we lack data. When we do the Medicare, when we do reviews based on Medicare data, is very non-specific. So some of the conclusions that are drawn are based on data that is not granular enough to draw conclusions. And that's why sometimes the conclusions may be more dogmatic rather than based on science. But coming back to the point of atherectomy, the overuse of it, I'm sure some of it is overused. I would agree with you, and I know of instances where it is overused. But at the same point, one of the challenges that has never been truly addressed in a study, which I believe is extremely important to look at, is the role of in-stent stenosis versus does the atherectomy help prevent in-stent stenosis? Because one of the things that is pretty, I would say, even if there's retrospective data, you would see that when people do atherectomy and angioplasty, the incidence of stent insertion goes down. I mean, that is pretty, I would suspect, acceptable to everybody. And when that happens, then the question is, because we don't know, I mean, there's data that shows that there's 30 to 40% in-stent stenosis rate over next 2 to 3 years. If that is the case, then these people come back for re-procedure or re-intervention. So we don't have data in which we can say, well, we have this segment in which we did angioplasty and stent, because many studies would suggest that angioplasty alone is not enough. We should be putting more stents than what we do. And so if we do that, then if we look at longitudinally, and if they get in-stent restenosis, what is the incidence of that and how many times we intervene? So over a 5-year period, overall, did these patients actually had more intervention because of in-stent stenosis, or less intervention because they had the atherectomy and did not have a stent put in? So the data like that is extremely important in my point of view, going forward, to see what the use of atherectomy should be. But if somebody is using maybe a laser atherectomy in a totally calcified lesion, that's probably not appropriate. You probably need a different device. If you have a renal population with severely calcified arteries, a certain percentage of patients on dialysis will need revascularization of the legs. They may end up with more atherectomy because the lesions are much more calcified. So the data like that is just not available in my point of view.
Yeah, I mean, you bring up a good point. I think the comparator groups in a lot of the studies related to atherectomy and other technologies are just not very good. I mean, a lot of the comparator groups in some of these studies are just plain balloon angioplasty versus X technology. That's not the right comparison. Nobody's using plain balloon angioplasty as a primary treatment algorithm in the femoral popliteal space currently, I don't think. There's drug-eluting technology, there's stenting, and then there's atherectomy, and now there's shockwave, as you mentioned. So we have like so many different technologies, and sort of the base control groups is sort of left in the dark ages a little bit. What worries me about atherectomy is that most of the studies that are out there do show a decrease in stenting with the use of atherectomy, but higher rates of sort of limb events in the acute setting, so embolization, and not really any better long-term outcomes compared to plain balloon angioplasty, which is sort of the most basic technology we have. So I worry, but I agree the data does not exist, that if you were to compare atherectomy outcomes compared to contemporary technology outcomes, that it would be a losing game for atherectomy.
Yeah, well, when we did publish a paper from our OBL, because most of the use or abuse, however you look at it, is in the outpatient setting, as you said. And our results we did not have the embolization rate some of the other devices may have. I'm not promoting one device or the other, but two primary devices that we were using in our OBL was the orbital atherectomy, and that's from CSI, and the laser that comes from Philips, which used to be Spectranetics. So those are the two main devices we use, and we did not have the embolization. I believe some of the technologies which kind of shave the plaque off have more tendency to embolize. And earlier on, when we were doing it in the hospital, or before we had our OBL, I did have a couple of incidents of when we were shaving off the plaque of embolization. I mean, that's a real risk. People use filter to avoid that, but that adds the cost of doing the atherectomy. Now, one of the abuses that may have been there, maybe because of what the atherectomy gets paid in the outpatient setting. And there's some misunderstanding about that. So I would just bring it up, and please clarify if you think I'm saying that you don't agree with Dr. Hicks, is that, so if you look at the code 37225, yes, all the CPT codes look at, in 2022 on an average, it pays $9,552. That is atherectomy and angioplasty in an OBL setting. That's what it gets paid. If you look at an angioplasty and a stent in the same setting in the OBL, which is 37226, the payment from CMS on an average is $8,911. So that is a difference of about $600 between if you just do a plain atherectomy and angioplasty versus atherectomy versus a balloon angioplasty and stent. and the cost of the device, cost of the atherectomy device, depending on how you negotiate what the price is, maybe somewhere between $1,500 and $2,500 to $100 to $3,000, depending on what device you're using and what contracts you have. So if you look at it financially, actually, it is better to do an angioplasty and stent versus atherectomy and angioplasty. Now, when you look at atherectomy, angioplasty, and stent, and that is code 37227, the price that the CMS there pays $12,240 on an average. So that gives a little bump up from the about $9,000 you get for angioplasty and stent, bump up about $3,000. But if you add the cost of the device in terms of that, so the profit margin is not there. In 2022, some of the payment for atherectomy procedures went down as compared to the previous few years, and next year maybe actually even worse, because the way, and what I always say that when a new technology comes, then the first few years CMS always pays more because they have not still figured out how to pay for a new technology. And I would suspect going forward, same thing will happen with Shockwave. They say, I wouldn't be surprised if a lot of atherectomy procedures move over to Shockwave, and then we will be in the same situation where Shockwave is probably being abused because CMS will overpay. I wouldn't say overpay, will pay more because of being a new technology.
I think you're completely right. I mean, the price differential for atherectomy sort of has been historically enormous. And it sounds like only $600 between a stent, for example, and an atherectomy catheter, but $600 on a population level actually equals a lot of money. So I've looked at this reimbursement concept in Medicare in 2019. Atherectomy devices accounted for about 53% of all procedures done for claudication, but accounted for 93% of the Medicare payouts for PVIs. So just like an astronomical price differential there. And I think you're right. Some of it's just due to new technology. CMS doesn't know how to run reimbursement. The challenge with that is that I think it can drive some bad behaviors, and that sort of ruins it for the people who are doing good behaviors. So if people who are using atherectomy appropriately, and they're being reimbursed accordingly for that, because it does take more time and the reimbursement for the device is expensive, but then you'll get these other subset of people that sort of see this financial opportunity and just use atherectomy all the time, and that's the challenge.
No, and I agree with you in that challenge. I agree with you that sometimes people, the question is, how do we make it better? The question always is, how do we improve that behavior? And now the multiple reasons in my point of view, and you can add to your reasons that you may think. One of the reasons is that we have three major societies: SVS, the cardiology, and the radiology, right? We don't have the single setup. We don't agree. I mean, the three societies themselves don't agree, especially below the knee. There's a lot of disagreement below the knee treatment, how we do that. So that's number one. Number two is that the societies have no tools of how to improve behavior. The registries don't do it. The certifications don't do it. I mean, for example, if in the venous space we had the certification that came through SVS, did that change any behavior? No. What we lack is the tools. All societies lack the tools, and I've had multiple discussions with, especially in the SVS itself, as to when we bring somebody to the SVS, that this person we believe is not providing appropriate treatment or overusing something or abusing something. Societies really have no teeth, no mechanism by which they can go to these people except general education. But the greed is unfortunately universal. There are doctors within the hospital systems who are doing inappropriate procedures. There were hysterectomies, there were carotid endarterectomies, there were aneurysm being done 4 centimeters and less finding the right indication. So how do we change that behavior is much tougher situation to handle, tougher problem to handle.
Yeah, no, I mean, that's absolutely true, right? We sort of know that these things are happening, and it's not just related to PVI alone. You're right. It sort of goes across not just even vascular surgery or cardiology or IR. It goes across all specialties. There's always some sort of overuse or arguable overuse of procedures. I do think, though, there are a few things that can be done. I mean, I think equalizing the margins across procedures would be a huge win. If you had the same margin, whether you did an angioplasty, an atherectomy, or a stent, meaning like the net revenue that you got back was the same, the financial drivers there would go down. And then I think the other thing, and which I've long been a proponent of, and I've done some work in this space in terms of venous intervention overuse, is providing physicians sort of their individual feedback. This is how you're doing, not at a punitive level, but compared to your peers, you're using atherectomy way more, way less, the same amount. And I think just sort of for a lot of people, especially people who want to do the right thing, understanding where they live in the context of sort of the greater community is huge. And VQI did that has done that on some level. They provide those reports sort of to give on an institutional basis an understanding of where you are in terms of like complications and other outcomes that they measure. The challenge, I think, with the institutional reporting, and we've seen this in NISQIP as well, is that a lot of physicians say, well, you know, our rates are not good because there's this, my partner so-and-so just does terrible work. Like there's a lot of sort of like non-accepting of sort of individual or personal contributions to the outcomes that are being reported. So I am a huge fan of personal, like physician level reporting. And that data exists. It's just a matter of one of the societies sort of deciding to do something with it.
No, I agree with that. The data is there. Again, there is the implementation of the data. How do you change behavior is always tough. Now, if you look at the margins, which you just said, actually, right now, a person should not be doing an atherectomy and angioplasty alone, because if you should be doing angioplasty and stent, because the margin of profit in an outpatient setting would be greater. Actually, if you look at it from a business side of it, if you just do an angioplasty and stent instead of doing atherectomy and angioplasty. So yes, it is a little bit more expensive. You're right. It's on a global level, on the Medicare level, but Medicare is paying $500 more per procedure. But then again, what I said earlier, we don't know how much more we spend down the line with in-stent stenosis. So that's how much do we do? Coming back to changing
I'll challenge you there, because I'm not sure if stent is the only other choice besides atherectomy. I mean, there's drug-coated balloons. There's really good results with drug-coated balloons. And then now lithotripsy. So I don't think it's just atherectomy or stent. That's not the only two choices that you have.
Yeah, so the drug-coated balloons, for a while, as you know, they went under a huge shadow because of the papers that came out with increased mortality. So they came under, for a while, they were, there was a warning from FDA. So for a while, their use went down, and now it may be coming back up again. But in an OBL, in the hospital system, if you use a drug-coated balloon, there is a separate, you get extra money. The hospital gets more money. The hospital collects the technical component. In an OBL setting, unfortunately, the CMS has chosen not to reimburse a drug-coated balloon or a drug-coated stent. They just have not. So that as drug-coated balloons are twice or more in cost as compared to a plain old balloon, simple balloon. And so one of the things that could be helpful as a society, we should be asking CMS to start reimbursing for drug-coating balloons with the cost in an outpatient setting, whether it be an OBL or an ASC. Yeah, so there's a lot of there's no coordination in terms of how we provide total care for our vascular patients. For example, I manage an ASC. And you'll be surprised to know, I was surprised to know, because I didn't know that happens. And do you know that if in ASC you do an angiogram and do not intervene, which sometimes would happen, you go do an angiogram, suddenly say, no, there's not enough to intervene. The angiogram doesn't get paid at all. I mean, you're not trying to do just an angiogram and diagnostic. You do with a intent to treat, but you end up doing an angiogram and say, no, there's not enough disease to treat. So what does it do? Number one, the ASC loses money, or it promotes the person who's doing this said, oh, there's a 30%, let me just dilate it. I won't lose the $1,000 or whatever the cost of the procedure is. So some of the things at the macro level need to be adjusted. For example, if the drug-coated balloons were paid in the OBL, I wouldn't be surprised if the use of atherectomy goes down, because ultimately all these doctors running businesses, I mean, they can't lose money on what they're doing at the end of the day, so long as they don't hurt the patient. The bottom line is nothing should be acceptable to anybody if anybody is doing something that will harm a patient.
Yeah, no, I agree. I mean, I think that getting back to kind of my concept that if the margins were equal across procedures, then people could use whatever technology they felt was best. And obviously, not reimbursing for a diagnostic angiogram is going to breed interventions that you don't need, because then no person doing a procedure in an ASC is going to just do a diagnostic angiogram. So there's many layers of sort of challenges. I think sort of we need to address them on multiple levels. The positive side, I would say, is that there's been a lot of discussion about this in the last year or two. Before I hadn't really heard anything about this. In the last couple of years, it's been a topic that's been discussed. So it's getting attention. CMS has noticed some of the sort of the drop in payments from atherectomy are a result of that. And I know that they're sort of looking on retooling. But I think, at a society level, we can do a lot more than we're doing. Although certainly sort of these types of conversations help.